Hey guys, I'm Chris Gallucci, and today I will be talking to you about a Lyme disease outbreak. The reason I chose this particular disease is because I am born and raised from Connecticut, where this disease was discovered. I remember summers where ticks would be so bad, where we actually used to shave our heads just to make it easier to search each other every time we come in from playing outside during the summer. My neighbor actually got Lyme disease, I want to say about 97 or 98. So it's always kind of been in the back of my mind, and I'm actually glad that I actually got to do research on this and share this with you guys. Now, Lyme disease isn't a particular outbreak that happened in a short time period, like you might say the Jack in the Box outbreak during the 90s, or Zika virus, or Ebola. Since the 70s, this has actually slowly increased and is actually getting worse and worse every year. And currently, Lyme disease is the most reported vector-borne illness in the United States, and I'll get into the history of it shortly. All right, so let's talk about a little history here. Beginning in about the early 70s in Lyme, Connecticut, and neighboring towns, East Haddam, Connecticut, there was a sudden emergence of children who had this rheumatoid arthritis-like symptoms, which was a little odd at the time because rheumatoid arthritis isn't exactly that common in children. So this was kind of like the initial indicator that something was wrong. Then you want to add the fact that researchers kind of figured out that in all these cases, they occurred, first of all, in the summer months. All the kids reported being bitten by a tick. Okay, kind of tells you something there. And in the area of the tick bite, there was this characteristic bullseye-like rash, which I'll talk about the rash later on, but that's kind of like the key indicator of Lyme disease. Now, given all these symptoms, researchers were able to put a name to this disease, and they named it Lyme disease after what was discovered in Lyme, Connecticut. And it actually wasn't until 1981 where a researcher, Dr. Willy Bergdorfer, and again, I'll talk about that later on, made the connection with the bacteria and the disease and whatnot. I'll save that for later. Now, this sudden rise of Lyme disease during the 1970s, it would make you think that it's a new pathogen, but studies have actually shown that this isn't true. They've actually found bacteria dating back from museum collections of ticks from the 1940s and from journals of American colonial settlers. And by tracing genetic variation in the population of these bacteria, they actually found that Lyme disease, or this particular bacteria that causes Lyme disease, has actually existed in the U.S. many thousands of years before European settlement. Okay, now here you'll see a picture of Dr. William Bergdorfer, who is credited with making a connection between Lyme disease, infected ticks, and the spiral-shaped bacteria, which later on was named after him and his role in this discovery, and is called, as you can see on the slide, Borrelia burgdorferi. Hopefully I'm saying that correctly. Now, this bacteria naturally occurs in reservoir hosts, including mice, squirrels, shrews, and other small invertebrates, and deer, deer are a huge problem in the Northeast, which may be one of the reasons about why it's so prevalent in that area. Now, the Ixodes scapularis and Ixodes pacificus, again, hopefully I'm pronouncing this correctly, those are black-legged and deer ticks known in the Northeast and the Pacific Northwest. They become infected with this bacteria while feeding on the blood of the natural reservoir hosts. Now, during the subsequent blood meals, the ticks can transmit the infection among the reservoir hosts or to incidental hosts, including humans. Although deer are not infected with this bacteria, they actually play a role in transporting ticks and maintaining tick populations. So real quick, I just wanted to show you a picture of what these black-legged ticks or deer ticks, or the western black-legged tick, actually look like. You'll see the nymph stages right here, and the adult male and adult female. It's just kind of for your own guys' reference. So here you see the case definition from the CDC. I'll let you kind of read through it. I just want to point out, though, that, like I've mentioned, the most common clinical marker is this bullseye sign, this rash that you get in the area where the tick bite is. You see the tick here and how it kind of extends out. It kind of starts as this red macule or papule, and within days and weeks will actually expand in size. Now, I think according to the case definition, proper diagnosis, it actually has to be greater than 5 centimeters at the largest portion of this rash to be considered Lyme disease. I'm not sure how correct that is, but that's just one of the sources that I found. Also, you may want to know that secondary lesions may occur if this bacteria is spreading, or you could be bit by multiple ticks and not even know it, so you might find multiple rashes. Now, there's other symptoms that usually occur with this. I wrote them at the bottom there: fatigue, fever, headache, stiff neck, arthritis, myalgia. Now, not everybody gets these symptoms. That's why it's kind of given as a list. And that's why finding this rash is so important. Going back to the example of my neighbor who had this, when I was talking to him, he said he had no other symptoms except the rash. He actually had it on the back of his neck. That's where they got him. And he just noticed that it just looked like a perfect bullseye. And the doctor knew right away what it was. So you got to be careful when you're going to these areas and just make sure that you do thorough searches, especially in the hair, because these rashes actually may be easy to miss. If these infections are left untreated, they actually can spread to the other parts of the body, causing more serious neurologic conditions such as meningitis or facial palsy, or even cardiac abnormalities within days or weeks. Again, depends on the person, depends on the age of the person, the health of the person. Over a period of months or years, an untreated infection can lead to mono or oligo articular arthritis, if I said that correct, peripheral neuropathy, or encephalopathy. So this is just another slide I want to show you guys with different ways this rash can actually present itself in different forms. Now, this bullseye one is clearly, it's the most evident one you're going to find, but like I said, it does manifest in different ways in different people sometimes, and every once in a while you will see it in these different forms of blistering lesions, uniformly red lesions, blue-red lesions, disseminated lesions. So you do have to be careful and kind of pay attention to all the other symptoms as well. You have to consider where you were, if you think you may have been bit by a tick, the time of year, if it was during the summer. All these kind of play into a role if you're not getting this characteristic bullseye sign. And again, there's also lab tests and lab criteria to find this bacteria, which I'll talk about. Now, for the purposes of surveillance, actually from the CDC, you'll see here the definition of a qualified laboratory assay. I'm not going to go through that for you. I'll just kind of briefly talk about it. Now, it takes a few weeks for someone with the bacteria to produce antibodies against it. Healthcare providers actually use one of two antibody tests as a first level screening. The screenings are actually designed to be very sensitive, meaning that almost everyone who has Lyme disease will test positive, including people who don't have it will test positive, giving you false positive results. If the screening test is negative, it is highly unlikely that the person has Lyme disease, and no further testing is needed. However, if the screening test is positive or indeterminate, sometimes they use a second test called the Western blot, which is very specific, meaning that it actually it's only positive for a person if they're truly positive with Lyme disease. The CDC doesn't recommend using the Western blot without conducting this first level blood screening, just for the fact that it can increase the potential for these false positive results since it is so sensitive, which will lead to ethical concerns over people without the disease getting treated for the disease. Now, in terms of treatment, a majority of these infections actually can be cured with antimicrobials such as oral doxycycline or amoxicillin. Now, patients with other manifestations of Lyme disease are treated with either oral or intravenous antimicrobials, depending on the specific clinical condition. Treatment for pregnant women is similar for treatment for others, but certain antibiotics are not used because of how it may affect the fetus. And after receiving this treatment for Lyme disease, patients actually may still experience muscle or joint aches and nervous system symptoms, such as trouble with memory and concentration. To help with these problems, researchers are actually trying to find out how long a person should take antibiotics for the various symptoms that are presenting themselves. Individuals who actually previously had Lyme disease actually can still be infected again if bitten by a tick. So national surveillance for Lyme disease began in the U.S. in about 1991, using a case definition based on clinical and laboratory settings. Now, the case definition was revised in 2008 and again in 2011, And as you'll see in the chart here, since about 2008, they actually started to include probable cases, which you'll see a little bit of a surge here, and then leveling off from about 2008 to 2014. From 95 until recently, if you notice a trend here, it's actually almost tripled in the number of cases reported, from about 12 to roughly about 34,000, with 96% of these cases coming from 14 states specifically, most of them in the Northeast. And this is why this isn't just a specific time frame. This isn't like a small condensed little outbreak of Lyme disease. This has been going on since the 70s, where you see this increase, and it could be contributed, not that there's more cases of Lyme disease, it could be more possible that the case definitions, maybe it's being diagnosed more, maybe it's being recognized more, maybe people are becoming more aware of it, but it's still an ongoing problem, and not just a specific isolated incident. Now this slide again is just for your reference here. When I mentioned that 96% of the cases of Lyme disease were reported from 14 states, these are those 14 states. Most of them are the Northeast. Now, just to give you an idea here, per 100,000 people, the highest right now is Maine at 87.9 cases per 100,000. Vermont is about 70.5 cases, and Connecticut is a little of the moderate side of the 14 states for 47.8 per 100,000 cases. Here's a graph, confirmed Lyme disease cases by month of disease onset. You notice here that most of the cases are typically reported in the summer months, like I mentioned earlier, from months of June and July, and a little bit in August. Here's a map showing where Lyme disease is most prevalent. Clearly you could see in the Northeast, you see the most number of cases. Now this is from 2001, but when I go to 2014, you see how much further the reach of Lyme disease goes. Now one of the reasons for this is it's postulated that migratory birds might be spreading it, not just deer. The ticks kind of piggyback on the bird as they migrate north or south. And some of the bird species that are expanding the ranges north, and studies of emergent Lyme disease in Quebec, Canada, suggest that the climate change actually makes it possible for tick vectors to survive in an area that once would have been thought to be too cold. Now, another reason might also explain this increase, including it could be a true increase in the number of infections, or as a result of the spreading of the different vectors, like I just mentioned. It could be enhanced surveillance, the case definitions, increased awareness among healthcare professionals and the public, misdiagnosis, and reporting errors. In the 6 reference states, Connecticut, Delaware, Massachusetts, Maryland, New Jersey, and Rhode Island, in which a majority of the counties regularly reported cases, there actually is a true increase in transmission that might have resulted from greater tick densities and encroachment of human development into rural and suburban areas. In other reference states, such as Minnesota, Pennsylvania, Wisconsin, there's a number of counties reporting cases that are increasing appreciably, suggesting an additional role for geographic expansion of reservoir mammals and vector ticks into these new areas. In certain states, especially those in the southeastern United States, Lyme disease surveillance is complicated by the occurrence of southern tick-associated rash illness, a condition that can actually resemble early Lyme disease, but it's actually not caused by the same bacteria. Now, this is an interesting chart I wanted to show you guys of confirmed Lyme disease cases by age and sex. If you look at the age group from about 5 to about 20 years old, you'll see such a disproportionate number of cases reported between males and females. And you also, if you look at the general shape of the curve, there's more cases reported in, it seems like, the younger population and then the middle-aged population. The reasons for that actually aren't known yet. Also, interestingly, the most commonly reported symptoms of bullseye rash and arthritis have been relatively stable since 1993. However, across age groups, the frequency of reported symptoms actually vary widely. For those under age 20 years old, the lowest percentage of the bullseye rash, 58.2%, And the highest percentage of arthritis, 38.7%, is reported for children between the ages of 10 and 14. These findings are interesting. They actually provide a basis to target interventions and have these prevention campaigns to specifically target these populations with this increasing incidence. I came across a study performed by Garnett et al., which essentially compared two different intervention strategies in reducing Lyme disease. Now, the first one was by using the method of deer hunting, which the idea was that if you reduce the deer population, you reduce the number of deer ticks, and then you therefore reduce Lyme disease. The second one was a use of this 4-poster device, which you'll see pictured here in this slide. I'll try to give you guys a visualization because I also had no idea what this was. Essentially, it's a central storage bin, this feeder system that attracts deer's feed. And on these use of these applicators or these rollers actually apply what's called an acaricide to the deer's fur, which they then spread through grooming themselves. And I guess an acaricide is a selectively targeted pesticide that specifically targets the species of ticks. And it actually, the results showed that this acaricide and this feeder systems were very successful in reducing and killing off these ticks. Now, one of the ways they measured the results of both the deer hunting and the 4-poster device was by checking the number of symptoms of Lyme disease that were reported in the area, specifically the bullseye rash. And they actually showed that the 4-poster device was actually effective in decreasing the incidence of the bullseye rash, yet the deer hunting wasn't effective at all and showed no statistically significant effect on the bullseye sign incidence, probably due to Lyme disease reporting issues, study design limitations, and small population size. At the end of the study, the researchers concluded that the combination of the 4-poster device as well as other interventions such as education may ultimately prove to be most successful in preventing Lyme disease in these endemic areas. So in 1998, the FDA actually approved a recombinant Lyme disease vaccine, which was then later withdrawn by the market from the manufacturer. And the reasons for that, I'm not entirely sure of. I couldn't find a reason. Current Lyme disease prevention efforts actually focus on a combination of methods and approaches, such as the use of acaricides, which I demonstrated earlier with the 4-poster device. Landscape management is another good one. Host-targeted interventions, management of deer populations. Although deer hunting actually hasn't been proven to show any statistically significant differences in Lyme disease. Personal protective measures such as insect repellent, and the most important one is just checking each other for ticks, especially if you live in the area. I mentioned earlier that I'd go outside, it wouldn't be for an hour, and I'd come in, my mother would find 2 or 3 ticks in my head. Although these methods are generally safe and inexpensive, the primary limitations of these methods are that their effectiveness has been difficult to demonstrate conclusively, and that the rates of compliance are actually generally pretty poor. An effective human Lyme disease vaccine that has been adequately evaluated in the highest risk population groups could actually be very beneficial in preventing Lyme disease. However, it would need to meet pretty high standards regarding safety, efficacy, cost, and public acceptance. Now, until an effective vaccine can be developed, the best way to prevent Lyme disease is to avoid contact with deer ticks, especially during the summer months when infections are the most common. Research supported by the CDC actually suggests that a tick must be attached to the body for at least 36 hours to transmit Lyme disease. So that's why checking yourself frequently is very important and can be a huge factor in reducing Lyme disease. You'll see here there's a little infographic on how to properly remove a tick. I'm not going to get into that. It's just for your own information. So that kind of concludes our discussion on Lyme disease and our Lyme disease outbreak. And like I said, this isn't a specific outbreak. It's not a specific instance where it's just like one isolated case over a couple months where we just had this surge in Lyme disease. And this has been going on since the 70s, and each year there's that slow, steady growth in a number of cases reported. Whether or not that's actually true cases or true incidence of the disease, or whether or not that's just better reporting methods, more recognition, since Lyme disease has only been really known about and given a definition since about the 1970s. Whether or not we actually see like a huge surge like we do with other diseases is yet to be seen. Maybe the weather factors, maybe there might be a sudden increase in tick populations. We don't know yet. But as for now, as the number of reported cases actually continue to increase, it kind of underscores the need for targeted preventive strategies, early disease recognition and treatment, and a sustainable surveillance system. Individual education regarding these personal protective measures needs to be stressed. Controlling deer population is another good bet for now. In addition, the need for training for clinicians to better recognize the symptoms so that it does not go misdiagnosed. But that's it, guys. Thank you for listening. And if you have any questions, just put your comments and I will talk to you soon.